Hi everyone, my name is Danielle and welcome to my presentation on heroin. Heroin is a highly addictive opioid that impacts individuals across all demographics. This presentation will take a look at the history, epidemiology, neurobiology, evaluation, and evidence-based therapies for heroin treatment using DSM-5-TR criteria and current national treatment guidelines. Heroin is a semi-synthetic opioid derived from morphine. It passes the blood-brain barrier in seconds, where it is converted back to morphine and binds to mu-opioid receptors, resulting in immediate and intense euphoria. The modern heroin supply is frequently tainted with fentanyl and its derivatives, which is responsible for the majority of opioid-related deaths in the U.S. These neurobiological and environmental elements contribute to heroin's exceptionally high addictive and deadly potential. Heroin was developed in the 19th century and promoted as a safer alternative to morphine. Dependence became obvious after a few decades. Over time, consumption extended from young urban males to large non-urban populations, fueled by lower cost and greater accessibility than prescription opioids. Heroin use in the United States has changed over the past 2 decades. According to national survey data, the percentage of people who have ever used heroin in their lifetime rose from about 0.33% to 1.6% between 2001 and 2013. During that same time period, the rate of heroin abuse increased from 0.21 to 0.69%. The largest increases have occurred among white adults aged 18 to 44, particularly in non-urban areas. This pattern mirrors the broader opioid epidemic, which began with prescription misuse and later shifted toward illicit heroin and fentanyl use. Today, fentanyl contamination plays a critical role in overdose deaths, with more than 70% of opioid-related fatalities involving heroin combined with fentanyl or similar analogs. These numbers remind us that heroin use is no longer confined to one demographic, making it a nationwide issue that continues to evolve. Prior non-medical opioid use, trauma, coexisting psychiatric illness, and economic difficulties are some risk factors. Young adults are the most susceptible, but urban minority communities continue to suffer systemic threats. Psychiatric comorbidities considerably raise the risk of relapse. In the short term, heroin produces extreme euphoria, followed by central nervous system depression. Chronic usage leads to tolerance and withdrawal, infectious and cardiovascular problems, and cognitive impairments. Spack et al. Discovered strong network links between craving, withdrawal, and psychosocial deterioration. During assessments, distinctive features such as pinpoint pupils, injection sites or track marks, and sleepiness are typically evident. Withdrawal symptoms include muscle aches, perspiration, and anxiousness. Patients frequently retreat from social situations and fail to fulfill their responsibilities. Monitor elderly persons for falls, sedation, and drug interactions. Heroin overdose is often caused by excessive opioid receptor activation, which suppresses respiratory centers in the brain. The risk has an increase due to widespread fentanyl contamination, which significantly enhances mortality even in low dosages. In certain circumstances, people purposefully take heroin while experiencing suicidal thoughts, exacerbating the suicide hazard. Naloxone is still the primary emergency treatment, rapidly correcting respiratory depression when taken quickly. Every opioid-exposed patient and family member should have access to and understand how to utilize naloxone. Heroin addiction is treated using evidence-based medication-assisted treatment. Buprenorphine, together with naloxone, are preferred in the majority of outpatient settings. Methadone is still required for severe dependence, although it requires frequent ECG and respiratory monitoring. After detoxification, extended-release naltrexone can be used as an agonist. Naloxone should be included in every medication-assisted treatment plan for heroin use. There is a correlation between treatment and mortality. Methadone is the drug that achieves the highest adherence and the greatest reduction in mortality, followed by buprenorphine. Despite that fact, naltrexone has a reduced retention rate. It's beneficial for those patients who are motivated. The most effective outcomes for relapse prevention and survival are achieved when behavioral therapy is combined with medication-assisted treatment. Behavioral approaches are essential companions to medication-assisted treatment because they address the psychological and social components of addiction. Cognitive behavioral therapy helps patients identify and modify distorted thoughts and behaviors that contribute to substance use. Contingency management uses structured incentives to reinforce abstinence and treatment engagement. Motivational interview aims to boost intrinsic motivation and resolve ambivalence about change. Trauma-informed care and family-based therapies promote emotional healing, strengthen relationships, and increase long-term stability. When these evidence-based therapies are combined with medication-assisted treatment, patients report higher treatment adherence, better coping skills, and longer-lasting sobriety. Patient education is one of the most powerful tools we have as psychiatric mental health nurse practitioners. Teaching overdose response, sterile injection techniques, infection prevention, and relapse cues fosters safety. Encourage hepatitis and HIV testing, vaccination, and use of syringe service programs if available in the area. When we take the time to educate patients and their families, we empower them to take ownership of their recovery. Referrals to addiction medicine, psychotherapy, and infectious disease services ensure that patients receive comprehensive care. During initial treatment, patients will be seen once a week, followed by monthly visits once they have stabilized. Urine screening, prescription drug monitor program evaluations, and suicidal ideation assessments should be done with each visit interaction. When treating older adults with opioid use disorder, safety becomes the top priority. Methadone can be effective but requires careful monitoring for QTC prolongation, sedation, and fall risk. Buprenorphine is often preferred for this population because it has a ceiling effect on respiratory depression, making it safer for patients with pulmonary or sleep-related conditions. Naltrexone should be used carefully in patients with liver disease due to the risk of hepatotoxicity. For all geriatric patients, it is important to perform regular medication reviews to check for interactions, screen for cognitive changes, and ensure vaccinations are current. These proactive steps reduce complications and support safe, sustained recovery. Heroin use disorder remains a major public health concern in the United States, affecting individuals, families, and entire communities. Effective treatment involves a multimodal strategy that includes evidence-based medication-assisted treatment, psychotherapy, harm reduction, and continuing support. As psychiatric mental health nurse practitioners, we have a unique opportunity to influence recovery at all levels. We're able to recognize warning signs, give life-saving medications like naloxone, manage withdrawal and stabilization with medication-assisted treatment, and provide the supportive environment that patients need to rebuild trust and self-worth. Research repeatedly shows that combining medication-assisted treatment with behavioral therapies leads to better outcomes. Patients stay in treatment longer, relapse less frequently, and have an improved quality of life. Recovery attempts to restore dignity, stability, and purpose, not just abstinence. When we practice with compassion, cultural awareness, and evidence-based skills, we can help patients transition from survival to long-term recovery. As always, thank you for watching my video.